afternoon, everybody. It's my pleasure to welcome you to today's MHF Top 10 webinar, Top 10 Lessons from Leads, Building Collaborative Health Systems. Our webinar series features top 10 insights into health and social systems, evidence-informed policymaking, and a range of key issues from forum experts and influential policymakers, stakeholders, and researchers from around the world. My name is Stephen Lott, and I'm the Senior Lead of Communications for the McMaster Health Forum. We're excited to have two great speakers here with us today, but before I introduce them, I wanted to note that there will be an opportunity for questions and answers later. Please use the chat box to ask your questions or share comments during the presentations. Also, if you have any feedback after today's event, please email us at forum@mcmaster.ca. And now to the reason that we're here. I'd like to welcome Bill Tholl, who currently serves as a Senior Policy Advisor, Executive Consultant, Author of Policy and Leadership Development. Until his rewirement in July 2017, he served as the founding president and CEO of Healthcare Can, the national voice of Canada's healthcare organizations. Prior to his appointment in March 2014, Bill was founding executive director of the Canadian Health Leadership Network, executive in residence at Royal Roads University, CEO and Secretary General of the Canadian Medical Association, and CEO of the Heart and Stroke Foundation of Canada. His early career was as a federal public servant with Health and Welfare Canada, serving in several senior roles advising deputy ministers and ministers. I'd also like to welcome Graham Dickson, a professor of leadership studies at Royal Roads University in Canada, and the recipient of the 2020 Distinguished Leadership Award from the Canadian College of Health Leaders. Graham is a principal in Leads Global, a not-for-profit enterprise that works closely with the Canadian College of Health Leaders in the use of the Leads framework nationally and internationally. He is also the research advisor to the Canadian Health Leadership Network, the Canadian Society of Physician Leaders, and on the governance board of Sanko Kondu, an international organization dedicated to leadership medical education. Graham also consulted with Health Workforce Australia on the creation of Health Leads Australia and the New South Wales Leadership Framework, which is similar to Canada's Leads. Also joining us today is John Lavis, the director of the McMaster Health Forum, who will share some of his insights and engage in discussion later in the webinar. We will start today's webinar with Graham and Bill, who will share insights into building collaborative health systems. From there, we'll open the webinar to questions and answers. But now, please welcome Bill and Graham.
Well, thanks very much, Steve and John. And Graham and I are looking forward to the webinar today. I'd like to start by acknowledging that I'm sitting here in Ottawa on the Algonquin people's lands, and everybody on the call is similarly kind of settlers, and I just want to begin by acknowledging that. Today is a special day. It's said that leadership is a journey, not a trip or a destination. And as I was reflecting on today and our relationship with McMaster University and John and his crew, that relationship goes back to at least March of 2014. And our first book on Leads, more of a conceptual piece. Today, we're fast forward. There's been a number of issue briefs and dialogue sessions hosted by the McMaster Forum between then and now. And we're pleased to be able to share with you today how Leads is being put to work based on our 2020 book. But John, I did want to say to you, I mean, part of the inspiration for writing the second book, at least for me, was the support and the encouragement that we've received over the around leadership and around Leads. So today, I guess it's next slide, Steve. So today, Graham and I would like to share with you what we're learning about how Leads is being put to work. We won't have time to go through everything in the book, of course, but we do want to kind of zoom out, give you a sense of what the leadership context is, and then maybe zoom in to some of the challenges, particularly at the provincial level, the jurisdictional level, in terms of health reforms that were ongoing before the crisis, or before the COVID crisis, and now are having to be navigated while also having to contend with the challenges around COVID. So Graham, over to you. Actually, the previous slide there, again, thanks, Steve. Graham, over to you.
Yeah, thank you, Bill. And I really appreciate the opportunity to be able to talk to all of you today. I'm wondering if I could ask all of the participants to turn their camera on. And can we, for a moment, Stephen, see a gallery view of everybody? It would
Sorry,
be helpful if we could see who is with us today. Is that a possibility or no?
unfortunately, it's just the cameras are for the panelists. So, but people can certainly use the chat to say hi and introduce themselves in the chat box on the right-hand side.
Okay, that's great. I wonder if I could ask people to put in the chat box on the right two things. First, their name, where you work, and a third thing, your familiarity with the LEADS framework, with the number 1, I'm not familiar at all, or the number 5, I understand it completely. I wonder if I could ask each of you put that into the chat box so Bill and I have a sense of who we're talking to today. That would be extremely helpful. I'll give you a minute or so to do that. Megan, thank you for doing that.
Suzanne?
A 3, Suzanne, a 3, Helen. Oh, jumped on me. Oh, there's a lot of 3s.
Mike is pretty aware.
Jonathan, 3. Okay, Jill, not familiar. All right. This is super, everybody. Thank you so much, Helena, too. We're going to be using the chat box a little today. We have another activity scheduled around slide 11 or 12 or so. And so I really appreciate you putting yourselves forward there, and please feel free to do so as we continue on today. So you've learned about us, we've learned a little about you, and I now turn it back to Bill, who's going to discuss the next slide. Bill?
So, thanks, Greg. So in the 90 minutes or so that we now have left, we wanted to cover 4 kind of bases. The first, and it's encouraging to see that most of you are at least familiar with LEADS to some degree, but we decided that we thought that it would be worthwhile to spend about 10 minutes just giving you the highlights, the overview of the framework and its genesis. The second one was one of the key themes to emerge from our 2020 book is that context, it's always been important, but it's particularly important in the context of the 21st century healthcare system. So we're going to share that with you, as well as sort of how context, the COVID context, is shaping how leaders lead. We're going to specifically focus in on how LEADS is being put to work within jurisdictions and between jurisdictions, with a focus today on OHTs, but we've also learned a lot from other provinces and other jurisdictions around how LEADS is being put to work. For example, in Saskatchewan Health Authority, the Manitoba Health, going back to the creation of the Alberta Health Authority. And then you all have hopefully had a chance to review the top 10 trailers, what we found new and exciting about this book in contrast to the first book. And we'll have hopefully some time to just kind of highlight 2 or 3 or 4 of the key things that we would encourage you to look at coming out of today's webinar. So with that, Graham, back to you.
Yes, and I'm going to, Stephen, start with the next slide on the LEADS primer. Want to give people a bit of an overview, not just of what LEADS is, but also where it came from. And initially, what I want to say about LEADS is that it is 5 domains of leadership action. It tries to describe what effective leaders do, regardless of context. And I say that knowing that everybody as a leader works in a different context, which means they have to adapt how they do the LEADS framework to the context they're in. The 5 domains of LEADS have 4 capabilities each. And why do we use the term capabilities? Because of the agile nature of leadership. Capabilities are bundles of competencies that can and be chosen from to adapt to situation and circumstance as it arises. So a capability is a much more sophisticated notion than a simple competency, in that people need to pick from a whole suite of competencies those that fit the situation they're facing. The second thing that I'd like you to know about leads, and I'm not going to go into great detail, but it does have both face and construct validity. It has a solid evidence base to it, but what we have found over the years since its inception, that people automatically can make sense of it from a face validity perspective. It speaks to them about what leadership does look like. And the third element that I'd like to emphasize is that leads isn't just a list of domains and capabilities of what good, effective leaders do. It is also can be used as a change model, and Bill will be speaking a little later about that in the context of OHTs. And I'm now going to talk a little about where it came from, which is the next slide, Steve. About, I would say 16 years ago, I was walking down what's called the Neptune Stairs at Royal Roads University towards the castle at Royal Roads University, talking to the vice president academic at the time. And he was lamenting about where the future of the institution was going. And he stopped and he said, you know, what we need more of at Royal Roads is leadership to take us into the future. And he stopped again and he said, leadership? He says, what is it? He says, to me, it's like fog. I can feel it and I can see it, but I can't grab a hold of it. And I realized at the time that if we're going to develop something, whatever that something is, we have to give it substance and form. And so when we were approached by the government of British Columbia during regionalization to develop an articulation of the capabilities needed to support leaders in British Columbia through the regionalization process, the idea of a leads framework was born. And over the next year or so, we consulted with people across the province, did our lit reviews, and developed the leads framework, which has since that time been actually enhanced through work across the country and brought forward across the country. And it's interesting, in an earlier conversation, John, you talked about OHTs being a proactive response to regionalization. In fact, this in Leeds was a reactive response because the government had already regionalized us and suddenly realized, oh, gee, we've got people going into these very major corporate situations and they don't know the skill set necessarily associated with them. Moving from a small cornerstone hospitals, for example, in a community to becoming the CEO of a region was quite a dramatic shift. Next slide, please, Stephen. Three fundamental ideas underpin leads. We felt it was very, very important not to simply argue that good leadership in healthcare is the same as good leadership in business. It is not. It is a different enterprise. It is probably one of the most complex enterprises invented by humankind. And as a consequence, with its particular mandate and purpose, we needed a framework that spoke to the culture of healthcare. So it's a by health for health framework. It embraces the notion of authentic and servant leadership. In other words, people in leadership roles are there to serve the health and wellness of others. And thirdly, it's a distributed leadership framework. Although it articulates the qualities of leadership people need to have, those qualities need to be distributed over a whole array of different people in order for a system to function effectively. Next slide, please, Stephen. So this is the framework itself. Here are the 5 domains. I'm not going to go through each individual domain and set of capabilities associated with them. I know Stephen is going to give you access to this brochure either through the chat box or after the session. But just be aware of what the 5 domains are about. There is the L, lead self. This is the inward-looking dimension of effective leadership. The leader you are is the person you are. And you have to work just as hard at becoming the leader other people need from you as you do about simply going out and fulfilling your own aspirations as a leader. The second domain of leads is engage others. And this is what I would call the interpersonal dimension of the leads framework. It's how you interact with individuals and groups in an organizational context to get the most out of them and yourselves, both as individuals and collectively. You've all heard the term engagement and you know what it means. Knowledge workers need to be engaged, and doctors, nurses, and others in this business called healthcare are knowledge workers. Then there is the A for achieve results in leads. Leaders are not just there to, how would I say it, build relationships, make life easy for people or hard, as the case may be. They're also there to get results, and those results are relative to the health and wellness of the people we serve. The D of leads is develop coalitions. And we recognized very early on that Canada is a very fragmented health system, calls itself a system, but it actually is not, according to Stephen Lewis and others. Indeed, provinces are not often health systems, as we've learned with the extended care situation during COVID. So the building of coalitions became absolutely fundamental for effective leadership, for systems to grow and develop. And obviously with OHTs, this is a fundamental dimension of the growth that's expected in the creation of OHTs. And finally, the S in leads is for systems transformation, which is simply an articulation of the fact that for all of us to make a system work, we must embrace certain capabilities of action system-wide around the change dynamics implicit in systems transformation. Now, it's important to note that the leads framework, even though they are 5 separate domains, are actually interdependent. The L and the leads, the L and the S, for example, are symbiotic. You can't change a system if you don't change who you are. The E and the D are about relationship building, interpersonal relationship building, and organizational relationship building. And all 4 of those are in service of getting the results that the leader and the system is trying to accomplish. So with that, I'll turn it back to Bill, who's going to talk a little about leads as a change model. Bill?
Yeah, thanks very much, Graham. So again, leads can be used to help each of you reach your full potential as a leader. And Graham's described how that builds, L-E-A-D-S. Today, we're going to focus on what's the focus of chapter 10 in the book, which is using leads as a change leadership tool or a change model in conjunction with other. It's not in competition with, but actually complements other well-known change models like Cotter's 8 steps or Bridges, psychological change models. So we're going to zero in today on leads as a change leadership tool, and in particular draw in a couple of the capabilities under the D, the carpooling metaphor that we're going to use a little bit later, and under the S, the need for systems thinking or critical thinking if we're to get to where we want to be in terms of a preferred future. So next slide. So we've reduced this to kind of 3 simple rules, and this is based, by the way, on over 30, maybe 35 mini case studies that are sprinkled throughout the book in terms of how leads has been put to work to help, if not transform the system, certainly change them and move towards that preferred future. And those 3 simple rules are, number 1, keep an eye on what the results are, what that preferred future is going to be, building on the acceptance that the current state is not sustainable or as I like to say, the quo has no status. And it's really important to have a clear and compelling way to communicate what the desired results are. And I always resort to Berwick and how he's changed the world in so many ways with IHI, triple aim, now quadruple aim, by simply saying to people, join with me to save 100,000 lives this year and for every year thereafter by eliminating avoidable adverse events. That for me, changed the world of patient safety and quality of care. Second, Graham's already said how important relationships are, and trust and reciprocity are to building trust, functional relationships, both individually and across organizations. And today we can, also say that as important as that is, how do you do that during a COVID crisis where everybody's working virtually? How more difficult is it to build those kind of relationships? And third, staying agile, being able to adjust as we go. I mean, we've heard about the EQ and the IQ. Well, we need to focus a little bit on the AQ, your agility quotient. And embedded in that is this notion of resilience. As we're dealing in this kind of unpredictable environment, how can we build resilience individually, like a muscle, by relying on networks and colleagues, but also organizationally? How do we build resilience organizationally in terms of pre-planning and through strategic partnerships and so forth? So, and all of those are in a dynamic, you'll notice the little arrows going back and forth, all of that's in a dynamic environment where, especially in COVID times, you have no idea what the next day or the next week or the next month's going to deliver in terms of new challenges. But as we'll point out a little later on the carpooling, maintaining a focus on what those desired results are is especially important during COVID times. So, Graham, back to you. And
thank you, Bill. Slide, please.
Just in the middle of that chart is context and how all leadership is a function of time, place, circumstance. And so Graham's going to give us a little bit more in terms of how important contextual leadership is.
Thanks, Bill. Yes, context matters. Time, situation, and circumstance determines what qualities of leadership are required to bring forth to respond to the needs of the situation. There's where the agility that Bill talked about before come in. The work of Ron Heifetz around adaptive leadership comes in here as well. And probably no more has that been obvious than during COVID-19. For example, when the day-to-day work on OHTs had to be put aside for a period of time so that we could respond to the context challenges of COVID-19, of which one obviously is, from the point of view of, say, the lead's capability of communicates effectively and engage others. Now communicating effectively means you also have to embrace the challenge of other people communicating irrationally, of debunking science. So not only do your communications have to be accurate around the science, they also have to catch the attention of people and debunk the negative communications that are out there. So that capability of leads has to express itself differently during COVID than maybe prior to COVID. Next slide, please, Stephen. I was very captured by this statement by Dr. Joanne Liu, who is the former CEO of Médecins Sans Frontières. She made the statement, the virus has no mercy. It exposes all our weaknesses, both individually and societally. And I think we have seen that on multiple fronts. Indeed, someone invented the term syndemic to describe actually the impact of the pandemic. In other words, a syndemic is a series of health pandemics that are merging together. For example, mental health issues, substance and abuse addictions issues that are all unanticipated consequences of a virus, but are our weaknesses coming to the fore as individuals and as society? Our extended care home situation is another one that's being shown to be clearly not up to what we would hope it to be. Our personal protective equipment supply chains, not up to what we hoped they would be. Our vaccination rollout, not what we would hope it to be. So actually, I'd like to stop talking at you now for a moment and ask you to think about the following question. Reflect on your own experience over the past 6 months. Can you identify one weakness, either personal, societal, or revealed in the health sector, that COVID-19 has exposed? If you can, type it in a phrase in the chat box for us to see. I talked about a few, but I'd like to hear some or see some that you have experienced, seen some weaknesses that you have seen exposed due to COVID-19. Take a moment to get your responses. Maybe I summarized them too well, Bill.
Oh, we'll wait just a minute here.
Pardon me?
Let's just wait a minute here and see whether we get it. But as we await that.
Here we go. Political decisions are not connected on the ground realities.
Right.
A problem before COVID, but certainly exacerbated by COVID, no question. Accessibility to vaccinations, not what we hoped they would be. Precarious work. Interesting phrase. Interesting phrase.
Yeah.
Thank you. So I'm not going to put you to a huge amount of effort here. We've got another interactive activity shortly. I'm going to turn it back to Bill, who's going to talk about VUCA environments. Bill.
Yes, next slide, please. So in the previous slide, Graham talked about weaknesses. And, when I think pretty much everybody's heard about VUCA in sort of the challenging sense, volatile, working and leading in volatile, uncertain, complex, and ambiguous.
This is Johnny.
And certainly, COVID kind of captures all of that and more. But just to pick up on what Graham said about weaknesses and how COVID is exposing both weaknesses and strengths, John and Greg Marshallton and others have written about just how decentralized our healthcare system is, right? One of the most, if not the most, decentralized system in the industrialized world. And of course, COVID is exposing some of those weaknesses, the fragmentation of that system. And Graham mentioned long-term care and kind of the sort of the lightning rod at the beginning of the crisis. So one of the things that we uncovered as we did the book was that there's another face to VUCA, and it picks up on leads as a change leadership tool. The importance of having that clarity, that clear and compelling vision. Berwick or JFK, get a man on the moon and back safely in the next 10 years, and how that changed the world. Understanding. Steve Covey tells us, first seek to understand before being understood. And so understanding sort of the nature of the challenges and the leadership challenges and how they're changing day to day, week to week, is really important to sort of counterbalance that uncertainty. And I'm going to refer a little bit later to the Stockdale Paradox to try and underscore that. Clarify, it's important what we're learning, and Graham and I are leading what we call an SSHRC, Social Sciences Humanities Research Council project into leading through COVID. And what are we learning as we're going through this experience? And one of the key things we're learning is the importance of communication, clarity of communicating, that it's important to communicate more often than not. Otherwise, people, as you know, kind of can make it up and assume the worst. And agility, again, we've spoken about the agility quotient, resilience, and the ability to kind of bounce back from adversity. And just to pick up on my earlier comment, if you imagine a 2x2 matrix with individual agility and resilience on the vertical and organizational resilience on the horizontal, you can move from just surviving this crisis by moving up to the top right of that quadrant in terms of actually thriving coming out of it, if you support the development of resilience both organizationally and individually. Next slide, please. Okay, Graham.
Thanks, Bill. And this slide, I just want to build on what Bill had to say. And I want to thank, by the way, Megan and Suzanne for a couple of their comments in the chat. The notion of weaknesses of COVID, of perpetual systemic racism, which has been clearly in our heads now for the last 8 months, is showing its ugly head constantly in the news again this morning, as I saw in my own local health authority. And inequality in health service workers, and not just the inequality in health service workers, but the challenge, again, of having to face a future health system where our workforce is burned out. And how are we going to truly respond to a problem that's been there for years and we paid little attention to it and is now going to be a huge issue moving forward? So you might be wondering about whether LEADS indeed is still applicable in the context of COVID. And of course, we think it is. How you respond to a situation like COVID, again, is contextually determined. But I've highlighted here 5 capabilities that I think we've seen very clearly demanded by the COVID crisis. The first, managing ourselves. Are we able to manage our own self-health, our own mental health, our own resilience, as we're trying to continue to serve the health and wellness of others and of our staff? Managing self is a huge demand that COVID has put upon us. That communicates effectively and contributes to a healthy organization is an absolutely fundamental function of leadership today, and will be going forward. Are we going to have the doctors and the nurses stay with us after COVID? Or are we going to have to be finding a whole new cadre of health workers who are going to come into a system that's exhausted? What are we going to do as leaders to ensure that our organizations remain healthy? Thirdly, under the A, taking action to implement decisions, in not studying problems over and over again, but actually stepping up to the plate to take the action that's necessary. And we have seen that happen a lot during COVID, and we'll have to continue to do so. The developed coalitions domain has been tremendously highlighted during COVID, and I could give you examples of multiple national and international coalitions that have arisen as a response to COVID, purposeful coalitions. And finally, out of systems transformation, the notion of encourage and support innovation. How have we seen that emerge during COVID? Hugely so. And therein shows the agility of many leaders. The question will be, how much of that innovation are we going to maintain? How much of it are we going to institutionalize without making it calcified? In other words, how agile are we going to continue to be as leaders moving forward? Next slide, please, Stephen. Another way of looking at leads is this notion of systems leadership. Leads is a framework that takes you from self, inward looking, furthest out you can go, which is a systems perspective, the zooming in and the zooming out, that is so much an attribute of systems leadership. And the elements of personal leadership involved with strategic engagement in a systems context is what is going to create the constructive results that we need in our system. As a leader, you're going to have to be zooming in and zooming out constantly to see what is necessary in the broader system. Go inside for the strength and the energy to accomplish it, and then move outside again to engage others to accomplish it. So the strategy element of leadership is fundamentally important, and that's why the D and the S capabilities, the A, the D, and the S capabilities of leads are so fundamentally important. Next slide, please, Stephen. When we got involved in writing the second edition of the book, we really realized that leadership, say as opposed to management, has three primary functions. And you only need leadership when these functions aren't being accomplished. The first function is the integration of services. If you have a fragmented system, then the first job as leadership is to overcome that fragmentation. It's to bring what otherwise would be disconnected parts into some form of harmony. We expect that of leaders. In fact, someone once said that leadership is the ability to overcome the natural tendency to fragment, the natural tendency to indulge one's silos, one's part, one's place in the system, as opposed to seeing yourself as part of a larger whole that must interact together and be integrated. And we've seen this, of course, in a multiplicity of ways in terms of clinical service delivery, how fragmented it can become. Second, primary function of leadership is to create both physically and psychologically healthy workplaces. That should be a priority for all leaders. It has not been a priority for many leaders in the past, and it needs to become that moving forward. And finally, and Bill's talked a little about this, and this is implicit in your OHT challenge, which is facilitating system change. Actually bring together a whole array of disparate parts to function as a whole on a regional basis to serve a population in a particular area. And leadership is going to be required to accomplish that. So Bill, you're going to say a little more about that now, so I'll turn it back to you.
Thanks, Graham. So that's the focus on the S, the systems transformation and systems leadership. Next slide, please, Steve. I'm going to speak to you about the first of the capabilities under the D domain, which is developing purposeful partnerships. And as Graham's already indicated, true transformational change can't happen on your own. You have to be able to work with others. And so as we looked at different examples, and I'll share with you on the next slide some of the different examples that I'm aware of, it all comes down to the metaphor that we use in the book is one of carpooling. So I'm going to imagine that John is here in Ottawa with me physically, and he and I know each other well enough that I asked John, do you want to carpool? Well, the first question that John is going to ask me is, where are we going? Because if he wants to go back to McMaster, Hamilton, and I want to go to Montreal, we're going to get to the 401 and one of us is going to be desperately disappointed. So it comes back to sharing that clear and compelling vision for the future and making sure that you're aligned, that you really want to go there. And key to that are some of the lead self capabilities and in particular character, honesty, and integrity. The second thing that John would ask me would be, so do you expect me to share in the gas and share in the driving? And so that speaks to the issue of sharing maybe in the financial risk of strategic partnerships, maybe sometimes the legal risks, and often overlooked reputational risk individually and organizationally. So you want to share in the effort and share in the risk. That's part of the E in leads. Now that we've sharing the same destination, let's back up to the sharing the same values. Bill likes to get there in a hurry. So if John is a white knuckle rider, he may not want to carpool with Bill. And may not want to, in terms of sharing the risk, share the speeding tickets going from here to McMaster. Along the way, we can probably expect, especially if we're going to through Toronto, a bunch of construction. So I might want to err on the side of sharing more rather than less with John in terms of the map and the GPS and so forth, just in case we run into some construction. And we'll want to utilize both our knowledge and mobilize it to kind of get to destination. And when we finally get there, we need to share the credit. Bill didn't drive all the way. He didn't pay for all the gas. And so you need to share the credit. And get this, it's infinitely divisible. And like your mom taught you, it's better given than taken. So we think there's a lot of power in that metaphor of carpooling, and maybe come back to it in the context of how it can and is being applied for the formation of OHTs. I guess there's 42, John, at present, and 86% of the population of Ontario, but we maybe want to come back to that. Next slide. Here are just some examples that we're aware of. Canterbury is an example drawn from New Zealand, where they reached out to over 1,000 of the people involved in trying to shape the new health and healthcare system, the new vision, and did so very successfully. So I encourage you to take a look at that in our book or online. The Greater Manchester, it's the Wigan deal, if you want to look it up. Again, very good example of a purposeful partnership that has worked to transform systems. The Health Charities Council of Canada, I was involved directly with that in terms of helping shape the creation of CIHR in a way that wasn't going to put health charities in Canada out of business. Again, happy to expand on that. Nova Scotia Health Authority, we feature the story shared by Dr. Peter Vaughan, the CEO, the inaugural CEO, actually the Deputy Minister of Health in Nova Scotia, and realizing the objective of forming one provincial health authority. And down at the bottom, if I were to ask what's an example of transformational change in Canada, I would take us back to the Senate committee report authored by Senator Mike Kirby, coming out of the shadows, and that led directly to, I think, a wholesale change in our attitude towards mental health and leveling playing field for mental health. And part of that was the formation of the Canadian Alliance on mental health, mental illness. So just some examples that I'm familiar with that have worked in terms of transforming change. I think that's the next slide, and then I think that takes us back to the context and the 3 rules as it might apply to OHTs. What are the results? What is that clear and compelling vision statement that's going to help everybody move in the same direction moving forward? How do we foster and support respectful relationships and allow each, kind of more of a bottoms-up approach to forming OHTs or strategic alliances, and then the focusing on the dynamics of change, self and system, as Graham has already described. So that takes us to the Q&A session, I think, John.
Yes, absolutely. Yep. Thank you both very much. We only have 16 minutes left, so I put a question, 2 questions in the chat box, one for folks who are outside Ontario, one for folks that are inside Ontario, and it speaks to Bill's last slide. So Steve, would you mind if we just went back 1 slide to get those 3 rules front and center? Because it would be great to hear from participants in the webinar about if you had to pick one based on a transformation or a big change that you've been involved in or are involved in, and including OHTs, which one would you give greater emphasis to? And while you're thinking about that, I just want to run something past Bill and Graham to get their reactions to it. I was so struck when I saw the rule. I'm used to your 5 buckets, but these 3 rules in an OHT context, Ontario Health Team context, are particularly interesting because OHTs are meant to ensure that these local health systems become clinically and fiscally accountable for delivering a full and coordinated continuum of care to a defined population. And a big part of that is moving from a more reactive approach to care to a more proactive population health management approach. And when I sat back and I thought, well, what are we doing to help teams? At the three parts of the OHT central program of supports most focused on this population health management transformation, I realized, well, it aligns perfectly with what you're saying, because for the results part, we have the health system performance network that is focused on those quadruple aim metrics: improving care experiences, improving health outcomes, keeping per capita costs manageable, keeping providers engaged. It's focused on that measurement piece. Second is the relationships, and we have the advance group led by Ross Baker and Paula Blackstein-Hirsch focused on collaborative leadership, because unlike regionalization in other provinces where they got rid of boards, we still have all of our boards, and now all of these boards of organizations need to be working collaboratively. So getting into the car, joining together in a carpool, and that requires a lot of relationship building. And now RISE is coming forward, the group that I'm involved in, trying to help with the change dynamics with both coaches and with collaboratives. So it actually lined up perfectly with what you're saying. So my question back to both of you is, have you found these to be similarly critical ingredients in other transformations akin to OHTs, that these come up again and again as being central? And it's not about picking one, it's about making sure that all of them are being spoken to?
Take a crack at it, Graham. Go ahead.
Thanks, Bill. I would, by actually referring to the chat box, John, somebody highlighted change dynamics, working at a provincial level. And I think what I've seen both in Saskatchewan and in Manitoba is both an effort to deal with the change dynamics, but not on, I would argue, not on what might be considered a systemic level. I think the Canterbury example Bill gave earlier profiles how you can use systems thinking tools to engage not just boards and providers in considering where the system is going, but also communities and family members in a very disciplined process, engaging huge numbers of people, setting direction for what has to be an integrated system going forward. And that's what the Canterbury example provided. In both the Saskatchewan and Manitoba example, it's a bit like the BC. You know, it was reactive. And as a consequence, people have spent their years building the regionalized process, piece by piece, running into this barrier, running into that barrier, because the recognition of the overall transformation for everyone who has a role in the system, and that includes patients and families, hasn't been thought about collectively, hasn't been discussed collectively. So in my way of thinking, where OHTs might benefit is looking at some of those very large engagement, coalition building tool kits that are available, processes that are available out there, to engage the whole OHT community in understanding the dynamics that they're going through and getting clarity on the results they want to achieve, and building the relationships at the same time you're dealing with the change dynamics. That's as good a response as I can give.
So very quickly, Johnny, the answer is yes. As we've looked at can you generalize the application of these three rules? The answer is yes. And there are different examples throughout the book. But I'd like to just amplify or build on what Graham said. Two key things in terms of applying these rules. One is around the whole issue of building and sustaining trusting relationships. So purposeful partnerships, if you really look at what the critical success factors, there are two. One is trust, and the second is reciprocity. So trust is hard to build, and like a windshield, once it's cracked, it's really hard to repair. And if you think about it, during a crisis like COVID, it's really hard to build relationships. So you tend to rely on existing relationships. And so
Can I add? Sorry, Bill, I interrupted you.
yeah, go ahead. I'll
I was
remember.
going to say one other lesson that I learned in the Saskatchewan example is the Saskatchewan system made the decision right up front that physicians were going to be partners in the transformation process. And they had a strategic policy direction that said, we're going to create dyads at every single level of the health system in Saskatchewan, from top, right, if you like, down to the level of frontline manager and leader. And they have fulfilled that promise in the process of moving forward. And so you will find partnerships of administrators and physicians working together at the most senior levels. They've also brought in, and Bill was going to highlight this as one of the top 10 from our book, they brought in very, very clear direction around patient and family engagement that other jurisdictions have not. And it's much more formalized in Saskatchewan than in other jurisdictions. And I'd encourage you to look at both of those. They're really very powerful.
So just to very quickly complete the thought. So trust, reciprocity. I encourage people to look at, if they haven't read the book by David Johnson called Trust, Top 20 Ways to Build a Better Country. He talks about trust as both grease and the glue that help move things forward. And I just strongly encourage you to read that. Second comment would be Malcolm Gladwell, another Canadian, recent book called Strangers, Communicating or Talking with Strangers. He makes the point that in a time like COVID, where you don't have time to build trust, assume it. 90% of the time, you will not be disappointed. So, and reciprocity, give and take. Strategic partnerships don't work, rule number 2, if you're just taking all the time and not giving and taking in that relationship, whether it's personal or organizational. So John, I know we're running a little bit out of time, but
so let me just say 4 quick things. One is I love the assumed trust, and I think too often we assume the reverse. But that's such a great comment, Bill. Second, when I talked about the collaborative leadership part, which is building block 6 in the OHT framework, what Graham's comment reminds me of is building block 3 is about patient partnership and community engagement. And often patients and communities have been left behind in the COVID response, but they're meant to be front and center in the OHT model. The third comment is just your point in the chat box, Bill, around turnover. And the COVID era we're in right now, at least in Ontario, is really tough on turnover because as each sector, long-term care, home care, others, encounters challenges, people are, marginally increasing hourly rates, tweaking benefits, doing stuff to attract more people in, but they're often taking them away from settings where those staff are needed in the first place. And then the final comment just speaks to Suzanne's really interesting point in the chat box. She said, go with rules 2 and 3, and then the results will come later. And my question to the two of you is, and I get Suzanne's point, and I think for the big dot measures, that's certainly true, but can we build in results that are more incremental as kind of enticement so we feel like we're moving the needle a bit while we work on the relationships and while we work on the other pieces?
Yeah, quick response is you need to have that destination in mind. And I'm always reminded about vision and so forth. I'm old enough, John, you're old enough to remember the original Alma Mater Declaration of 1978. Health for all by year 2000. And when we didn't get to health for all by year 2000, we reinvented it and said health for all by year 2020. So it's important to have those longer term, a real clear focus on what that longer term vision is. But you're absolutely right. You need intermediate targets. You need, as John Carter talks about it, you need some early wins or you're not going to be able to keep the team moving forward. So just to agree with what.
Great, super. Given we just have 5 minutes left, I wonder, Bill and Graham, would you mind, as maybe Steve, could you just go forward 2 slides? Could you just hit some of the highlights of the book? So
I'm just going to go for it really, really quickly.
Yep.
So you all have had a chance to look at the top 10 takeaways, but we're most proud of the 5 invited chapters, I guess. Steve, just kind of next one. Well, we'll skip through that one. It's important, but Ivy Burgo, instead of having a single chapter on equity, diversity, and inclusiveness, we approached Ivy to write EDI boxes throughout. And the quote, "Leads has had an emancipating effect on me and other women. It allows you to lead from where you are and who you are." Next one. Chapter 14 is written by 3 outstanding Indigenous health leaders, Dr. Alika LaFontaine, Carolyn Linston-Jones, and Karen Lawford from Queen's University. Again, they talk about how Leads works for them in an Indigenous cultural context. And that was a real test. We were most worried about that chapter. And it turned out, if there's one chapter that I would read above all, it's that one. Next one. And we talk about people-centered care, but as Aesop reminded us, when all is said and done, more has been said than done in this country around patient-centered care. There's a great chapter that's been written by Kathy Cole on the left there, the director in Saskatchewan Health Authority, and 2 outstanding patient advocates about how we can take that more seriously. Next one. Is it time to professionalize leadership? So the Canadian Society of Physician Leaders, and Graham's been working very closely with them, are looking at maybe we do have all that's required to start professionalizing leadership when it comes to, let's say, a subspecialization in medicine. Next slide. And Stockdale Paradox. I just encourage you all to go onto the YouTube, listen to Jim Collins and how Admiral Stockdale got through at 7.5 years in hotel at Hanoi by staying true to himself and that he's going to get through this, but facing the brutal facts. I think that's helpful as we deal with these challenges around COVID. So please look at Jim Collins, Stockdale Paradox, YouTube. Next, final. And finally, just to underscore it, it's leads in a caring environment. It's the caring element of leads, and Graham's already spoken to that, coming from the heart, a sincere servant leadership, authentic leadership in a caring environment. Next. That's it. That's our book if you want to go and get it. And I guess the last one would be, thank you again, John, Steve, McMaster. You guys have been an inspiration to Graham and I and to so many others. And it was just a delight to have been able to spend this time with you and people in the world.
Well, thank you very much, Bill and Graham. Your first book was absolutely superb, and I've read a few isolated chapters of the second, but I've got the book with me, and I'm looking forward to diving in the second one, which really pulls it together. And the timing couldn't be better for Ontario, given this transformation that we're in the middle of within the overlay of COVID, and so many of the lessons that you've drawn out are applicable right now. I have often found the leadership literature to be a bit impenetrable and not as immediately actionable as I would like, but you two have a gift for drawing out what we can use and apply it in the real world. And you give so many examples that can show us how things can be better with effective leadership. So we're very grateful to you. Our commitment is to get this recording out to all the Ontario Health teams and many other people across Canada, because we think it's really essential that your messages get out to a broad community. So thank you for letting us record this today. And with your permission, we're going to make sure that many, many hundreds of leaders see this, and we hope that it inspires them in the way that it's inspired us. So thank you very, very much for joining us today. Thank you for those of you who are able to join us live. We'll get out the recording relatively soon. We'll also promote it in our newsletter. So thanks for joining us, and thanks Bill and Graham again. Good to see you both. Thank you.
Thanks, Steve.
Have a good rest of the day. Thanks, Steve.
Thank you.